Dinesh? Yeah, we are waiting for your signal, okay?
Good evening. A promise of new dawn line in coming together, bringing together, and working together, which are perhaps our greatest strength that empower us peer into the future and impart shape to the healthier and happier tomorrow. Good evening, doctors. Behalf of Alkem team, I am Dr. Abhijit Trailokya, heading the Alkem Laboratories. Welcome you for this Dentex webinar series 2020. We thank you for joining hands with us in our joint mission towards a healthier and happier India. And we are thankful to you for commitment to the strong partnership that bring us together. Dentex has been conceived and coordinated by Dr. Suchetan Pradhan, who is also our scientific program coordinator and is supported by unrestricted educational grant from Alkem Laboratories Limited, Mumbai, a makers of prestigious brand like Clavoman and Zoflam. Dr. Suchetan Pradhan, our scientific program coordinator, has over 30 years of experience in the field of dental implantology. He has, used virtually all implant system available in market. He has been invited to lecture extensively, and has conducted several workshops over 25 countries on cosmetic dentistry, laser dentistry, prosthodontics, and implant dentistry, including the prestigious Harvard School of Dental Medicine. He has published several papers and has, authored chapters on lasers in implant dentistry, lasers in implant dentistry in the textbook entitled Lasers in Dentistry, published by Springer in 2017. He is also a director of Department of Laser Dentistry, Manipal Academy of Higher Education, Manipal. He is an international speaker for Nobel Biocare and BioLess. He has also been speaker at all the world tour. He is the director of Pradhan Dental Center. His area of research focus on use of lasers in implant dentistry, aesthetic dentistry, and digital dentistry. He's a man blessed with both healing hands as well as caring hearts. Uh, we do hope all of you have memorable Dentex program with us. Let's welcome our scientific program coordinator and the speaker of Dentex webinar series, Dr. Suchetan Pradhan. So over to you, sir. Thank you very much.
Thank you very much, Doc, for a lovely introduction of me. I'm also running the D.Y. Patil Fellowship Program in Implant and Laser Dentistry. And so today we had this webinar last month, and that was on digital dentistry, which is a new field of dentistry. Today we're going to talk about advanced implant dentistry, which means we're going to talk about sinus lifting procedures and full arch rehabilitation in medically compromised situation. Because, geriatric dentistry is something that we have to really consider as a day-to-day part of our practices, and to treat these patients, most of whom are medically compromised, and to be able to deliver the kind of prosthetic options that we have is what we're going to discuss today. So I'm going to start sharing my screen. So today we are going to, this is the first of many in the Dentex webinar series, I hope. And we're talking about advanced clinical dentistry. And this will be an ongoing process that we will want to educate our colleagues at the highest possible levels. So today we're going to talk about advanced implantology, which will include sinus grafts, full arch edentulous restorations, specifically in medically compromised situations. And this, I've been helped with by Dr. Siddhant Pradhan, who's an MDS in oral surgery. And this is a small part of my biodata, which Dr. Abhijit was very kind enough to introduce me. What I'm really proud of is my contribution to this, to the textbook of laser dentistry, which is called current concepts, lasers in dentistry. And I have a chapter on lasers in implant dentistry. And next webinar, we will speak. Today also, you will see some cases where we use lasers and how we can optimize the implant practices with lasers. And we will look at that as well. This is my some of my practice colleagues that work with us in Pradhan Dental Center. And as you can see, I do not like competition. So are we going to have a poll at this point?
Yeah, before you begin, I'm just going to share the results of the poll so far.
Okay.
You'll have to turn your screen sharing off for a second.
Yeah.
Okay. So how many of you are doing implants in your practice? 45% are doing it themselves.
So that's very interesting. Only about 50% of the people are doing it themselves, which is, and I get somebody else to do it. So probably they're getting some specialist to do it. 11.8% refer them out, which is also a great thing. And 18.5% don't do it. So that's, if you don't do it, then you have to have an option that you can refer it out to somebody or get somebody to do it in your practices, because all patients need implants as of today. So we have 150 participants who have polled in this poll, and so that's a very interesting thing. And we will have many such polls during the course of our presentation today. So let's start with our presentation. Siddhant, you'll have to stop your.
Yeah, I've stopped. It's
okay. Thank you. And Siddhant will be also coordinating the questions. So please keep sending in your questions. If we find something interesting in the middle, he will ask us to answer. Siddhant, you can stop me and I will answer it. Okay? Or maybe we can take it in between the segments. What we're looking at is sinus lifts, because a lot of times when you have implants to be placed above the sinuses in the molar areas or the premolar areas, you do not have adequate amounts of bone available. So this is something that you must add to your armamentarium once you're starting to do a lot of implants in your practice. It's the most frequently performed surgical procedure to increase the vertical bone height of the posterior maxilla in preparation for the dental implant placement. And it was first described by Hill Tatum in 1976. So it is not something that is an absolutely new procedure. Hilt was always, and I've had the pleasure of meeting him, Hilt was always somebody who was at the edge, cutting edge of dentistry. And it was later published by Boyne and James in 1980. It has a very high clinical success rate of greater than 90%, but it is important to understand that there is a learning curve to it, and that the more training that you get, the better you're going to get it. So let us look at the anatomy of the maxillary antrum. It is basically a pyramid-shaped pneumatic space, which is adjacent to the nasal wall, and the apex is pointing towards the zygoma. So it is the largest bilateral air sinus located in the body of the maxilla. And it opens into the middle nasal meatus, or the nasal cavity, with single or multiple openings. And we will see why that is important. Because if that opening is blocked, you will have a problem with the healing if there's a minor infection there during the procedure. So what are the boundaries of the maxillary sinus? The orbit is a superior boundary. The posterior wall, there will be a posterior wall, and there will be also the nasal cavity itself will be the anterior wall, and you will have an inferior wall which is bounded by, which is really the area of concern that we have in dentistry, because that's where you will be. So the floor of the maxillary sinus is where the roots of the molars are and the roots of the premolars are, and that's where you will be doing the bone grafting procedures by lifting up the Schneiderian membrane. The ostium is a very important part, and the middle meatus is what we are looking at, because the sinus drains into the nasal, through the nasal cavity, through the middle meatus, and if that is blocked, then the drain of the maxillary sinus is not going to be possible. You will then have chronic, the complete no-no for doing a maxillary sinusitis, because even if you do a even if you do a maxillary a sinus lift procedure, you can have infection and the bone will get infected, and then you will have problems with the procedure. So make sure that your middle meatus is open and the patient is draining through that area quite completely. The floor of the maxillary sinus is what we are looking at and is what we are really concerned about. And that floor of the maxillary sinus is determined by the roots. If you have had extractions done a long time back, there will be pneumatization of the sinus, and the amount of available bone to place implants will become smaller and smaller. This is not a static process. This is a dynamic process that happens over a period of time. So when you're doing extractions of the molars, make sure that you do them atraumatically. And by atraumatic extractions, if you can separate the roots out and extract them individually rather than doing, unless it's a mobile tooth, of course, but if you're doing an extraction where you haven't separated the roots, you're more likely to damage the residual alveolar bone, and that will give you less amounts of bone to do a sinus lift. The sinus itself can have multiple septa in it, and that is one of the areas that you must identify where the septas are, because while you're doing the procedures, if you encounter a septa, you may have to open another window. And we will show you some cases that we've had to do like that. But the important issue is that when you take a CBCT, and a CBCT is an absolute must for a sinus lift procedure. We were doing sinus lifts even before CBCTs were available in our practices. But as of today, I think in most areas in the country, unless they're really small rural centers, you will have accessibility to CBCTs. And I would recommend that this should be done in every single case. So the variations of septa can be multiple. You can have a septum like in picture 1, which are just small projections into the sinus, multiple small projections. You could have only one projection up to the middle part of the sinus, which is actually, we're not going to go beyond that for bone grafting in our procedures for dentistry. In number 3, again, you have long multiple septa. Number 4, you have a septa which actually divides the sinus into 2. Sometimes you can have 3 or even 4 divisions in the sinus. And that makes it really difficult for us, because for each, if you're going to place multiple implants there, for each implant then you will have to do a separate sinus grafting procedure. You can also have a lateral septum, which is really not going to be concerning dentistry so much, unless it is very low down, which we have rarely found. The blood supply, and this is very important to understand, comes out of the maxillary artery, and then there is the posterior superior alveolar, which then gets into the middle superior alveolar and the anterior superior alveolar. So this part of the maxillary artery goes through the lateral wall of the sinus, and that is really, apart from the Schneiderian membrane, your only real anatomical structure that can cause you problems. So make sure that you can identify this structure on your CBCT, and I'll show you 1 or 2 cases where you can do it, because it traverses through a groove on the lateral wall of the maxillary sinus. So if you've had a lot of resorption of the alveolar ridge, and unfortunately your sinus artery is very low, then that will be a cause of concern, and you will have to identify and then make sure that you do not damage the artery. That's the only other anatomical structure that can cause concern apart from the Schneiderian membrane. Once you've identified that, you can actually then go around it and do your sinus lift procedure. So this is something that you will have to be considerate towards. You also have a nerve supply. This is really not a problem for us. There is really nothing that you can damage and cause paresthesia. So it's really not something that concerns us, but this is the nerve supply to the maxillary sinus. This is very, very important to understand, that there is an epithelial layer. The Schneiderian membrane is an epithelial layer, and that membrane covers the bony contours of the sinus, so that is exactly what we are trying to lift. And the Schneiderian membrane is a mucous membrane that covers the inner part of the maxillary sinus. It consists of an overlaid periosteum and is a pseudostratified ciliated epithelium, and it's a highly vascular connective tissue. So don't get alarmed if there is a little bit of bleeding when you first dissect the Schneiderian membrane from the underlying bone. The thickness of the Schneiderian membrane is approximately 1 millimeter. The thinner the membrane, the more difficult the procedure. The thicker the membrane, the easier the procedure. And mucosal lining above 4 millimeters is considered pathological. And when you have a pathology, you have to be very careful, because you could infect the bone that you're going to graft. What are the indications for the sinus lift procedure? The primary indication for the sinus graft surgery is the implant reconstruction of the edentulous posterior maxilla, which is afflicted with post-extraction alveolar bone loss, and there's a pneumatization of the sinus. Because there is been resulting in a bone which is too atrophic for the implant placement. Of course, if you have adequate bone available, then you don't need to do a sinus lift. Also, there are two different types of sinus lifts that procedures that we can do. One is a lateral wall technique, and one is through the osteotomy site of preparation, which is the Somers technique. We are not going to discuss the Somers technique, because that's really only useful in very limited amounts of graft that you will need to do. While for most cases and most successful procedures are the lateral wall techniques. So what is the preoperative evaluation that we need to do? We need to do a comprehensive history and physical examination before initiating surgical treatment. The pertinent positives in history are upper respiratory infection, chronic sinus disease, chronic sinus facial pain, history of nasal or sinus surgery, history of prior attempts at maxillary reconstruction, and history of smoking. A lot of times, a lot of patients come to you with sinus grafts that have been performed and have failed, and that is the more difficult solution that you'll have to offer them, and you'll have to evaluate it properly. History of smoking. Smoking, is that a contraindication? It's not an absolute contraindication, but a higher rate of failure. So what I will recommend, and most smokers will not give it up, they would rather not undergo a sinus lift rather than give up smoking. So what we tell them is, please, 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 at least don't smoke for the first 24 hours when the healing potential of the tissues is determined to begin with. You will also, the other contraindications are the general implant contraindications, like the medical contraindications. So if a patient can't undergo surgery, obviously he cannot undergo implant procedures, and for sure he cannot undergo a sinus graft procedure. If there is a sinusitis or dental infections which are surrounding or neighboring that area, you will have to treat them first, especially if there are any cysts or granulomas associated with molars around the area. There will be a cross infection, and one has to be really careful. You got to treat that infection first, or at least treat it at the same time as you're doing this procedure. And if you have sinusitis, please get it treated by the relevant physician before you do the graft procedures. And of course, if you have cysts, polyps, or tumors of the sinus, that is self-explanatory. Obviously, you can't do the procedure until that is being treated by the relevant specialist. So what is the technique? You have the direct or the lateral window technique. It was first, again, like I said before, demonstrated by Hilt Tatum using a modified Colwell-Luck approach. So the surgical technique is very simple. It consists of osteotomies to make a bony window and So you make the bony window, and either you infracture the bony window, so that forms the superior aspect of your new sinus morphology, or medial rotation of this window, so that, which is the same as infracture, or removal of this window, which is called outfracture, without perforating the sinus membrane. So when you're outfracturing it, if the membrane is very thin, you have to be, that is one of your pressure points in doing the procedure. So if the membrane is very thin, normally I tend to infracture. If the membrane is reasonably thick, if it's 2 millimeters and above, then you can remove the bony window or outfracture it quite easily. Sometimes the membranes are very adherent, and again, that is your pressure point. So what is the technique? Of course, you will need LA infiltration. You will need a crestal incision and a vertical releasing incision. You will then raise a mucoperiosteal flap to expose the lateral sinus wall. And this is, again, a very critical consideration for the technique of the sinus graft. You will then make a lateral window. You can use a large round burr. We normally use a diamond, surgical diamond burr. You can either make a rectangular, or I can show you both, rectangular or an oval window. We prefer to use an oval because there are no sharp margins around that area, wherein you have some danger of perforating the Schneiderian membrane. So we can either use a large round burr, normal surgical technique. We can use a piezoelectric instrument, or we can even use a erbium family of lasers. In my practice, most of the times we just use the age-old large diamond burr technique. Avoid lacerating the sinus membrane. There is 30% of perforation of the membrane as reported in the various studies published. In our practice, I think it would be a slightly lesser number because we've been doing it for a reasonable number of years, and we do a large number of cases. And then you push the sinus membrane medially to create a subantral space. Remember, the rest of the sinus is an air space. So when you push the sinus membrane medially, you will create a subantral space, and that is the space you will do your graft. You will place your graft material and or implant simultaneously. If there is adequate amounts of bone available over the membrane to be able to get initial stability of your implant. Ideally, one should have 3 millimeters or more bone available so that you can do simultaneous sinus graft as well as implant placement, which is really the preferred choice of technique in my textbook. So the flap design, the crestal incision is made from the maxillary tuberosity to a point just anterior to the anterior border of the sinus, as you can see here. Then the vertical releasing incisions are made in the anterior and sometimes in the posterior aspect to the depth of the vestibule if you're making an envelope flap. Other times you may only need to do an anterior vertical releasing incision, and you may omit the posterior vertical releasing incisions. The most important point here, and the pressure point, is that the incisions must allow adequate exposure of the sinus and should not be placed in the area of the sinus window. If you don't have at least 3 to 4 millimeters above the superior area of your window, then your flap opening is compromised because it will interfere with your surgical procedure, and also your vision will be limited. After you've done this, you will elevate a full thickness mucoperiosteal flap, exposing the lateral wall of the maxilla. Once you've exposed this, as you can see now, we have a large exposure of the lateral wall. You have to then identify where is your sinus wall inferior superiorly beginning, because you have to start 2 millimeters above the inferior aspect of the sinus. So wherever there is the inferior most point of the sinus, you will start your drilling protocol with your burr 2 millimeters above that, so that when you lift up the Schneiderian, you have to lift up the Schneiderian membrane, not lift down the Schneiderian membrane. You can't do that. And so that's very important. Also, you must make a window large enough. Again, that's a pressure point to accommodate your instrumentation. Because if you have a too small a window, even if it's a single tooth sinus graft procedure, you will still need to make a large enough window to accommodate your curettes that will lift up the Schneiderian membrane. The superior horizontal osteotomy is then performed at the level of the planned augmentation height, because you must be able to also release the superior aspect of the Schneiderian membrane. So you're releasing the Schneiderian membrane from all sides: medial, lateral, inferior, and superior. So then the superior and inferior osteotomies are then connected with the anterior and posterior vertical osteotomies. You got to be very careful if you're using a diamond burr. This is, of course, a carbide or a diamond. We don't use a carbide anymore. This is a very old picture, and that's why you're seeing that. But if you're using even a diamond burr, you have to make sure that you do not damage the Schneiderian. The good part is that once you're close to the Schneiderian membrane, you will see a purplish appearance, and I'll show you in a lot of videos that we're going to show you. And in the purplish appearance, you will make sure that when you see that, then you start being very careful. And this is, again, a very important pressure point in your osteotomy preparation for the lateral wall sinus lift. You then start elevating it. Ideally, you will start elevating the anterior or the medial part of the Schneiderian membrane first, and then you will go into the inferior part, and then you will release it from the lateral, the posterior part, and then you will go to the superior part. So that is how I do it: mesial, inferior, lateral or posterior, and then the superior. Make sure that you do not use a sharp instrumentation here. We recommend using blunt curettes or broad-based freers. The membrane can then and should be elevated higher than the superior osteotomy to prevent excessive pressure on the graft material, because you don't want to pack it too tight, especially if you're using bone chips along with your whether they're allografts or they're autogenous, and we use a mix of both ideally, because that will give you the best results. You have sharp edges, and that can also, because the membrane is so fragile that while you're packing it too deep, too tight, it can cause a perforation of the membrane. So again, that's a pressure point when you're packing the membrane. Once the membrane is elevated, the bone graft material is placed under the membrane in an anterior and inferior direction. The graft should contact, and very important pressure point, contact the medial wall of the maxillary sinus. The graft is placed in the cavity loosely, but not, and should not be overpacked, but not so loose that you will have soft tissue infiltration back. The surgeon should always add an approximate 20% more to compensate for the last loss of graft volume. Normally, you would get 20 to 30% less graft than you have actually used the material with. The bone graft material chosen must provide viable bone to encourage osseointegration. So autogenous grafts are actually the gold standard for the sinus grafts, and their main advantage is their osteogenic capacity. Increased morbidity and limited availability and high resorption rates make allografts less desirable. These are the studies which have been done so far. Lots of studies have been done, and this is one of the review articles that I took this from. And here again, you can see that autogenous plus xenografts gives you really the best results. Okay, just full autogenous will give you absolutely the best results. But then to get that amount of graft, you will have to create another morbidity site, a morbid site, that can have a morbidity for the patient, and that can have consequences for the patient. So we tend to use lesser amounts of autogenous and more allografts. We use DFDBs, demineralized freeze-dried bone, something like Puros or something like Bios. And we also use membranes if needed, definitely if there is a minor perforation of the Schneiderian membrane. So implant placement, simultaneous or delayed. If there is adequate alveolar bone to stabilize the implant sites are prepared and the implants are placed before the bone graft with the bone graft material we pack around the implants. Most of the cases that we do, if there is 3 millimeters of bone, we will do simultaneous graft and implant placement, because the implant itself has a tent-like effect and it stabilizes the membrane also. Cha found that 98.91% of 264 implants with greater than 4 millimeters of alveolar bone height survived. And in our practice, I think we haven't done, we should do a study, and I will publish the results very shortly. We are in the process of doing it. So, Siddhant, can we?
Yeah, I'm just going to swap over to the poll for a second before we go on.
I'll have to stop sharing.
Yeah.
I don't know why. Yeah, I'm going to stop sharing and then
okay.
you can go ahead.
Okay, so this is the number of people that are actually doing sinus lifts in their practices. 35% do it themselves. 32% don't do it at all.
Okay, and so that means 34. 1/3 of all dentists are doing sinus lifts in their practices. That is a very impressive figure. If somebody else does it, that's 21%. About 50% of the people don't offer sinus lift as an option in their practices. And I think as time goes by, you will find more and more people will do this. So again, we will publish the poll results at the end, because that's very interesting, and I'm getting more and more votes coming in from the participants. And let's look at all the cases that we are. Sid, can you, Siddhant, can you stop sharing? Yeah,
there you go.
Share. And now let's look at some of the cases that we've done in our practices. So the first case, you can see the preoperative CBCT. You have very little bone there. We're creating a window to gain access to the sinus membrane. Here we're using a piezo electric unit. And I'm using a rectangular window. I'm lifting up the bony window, out-fractured it, lift up the sinus membrane. And you can see that we've got a beautiful superior wall of the membrane there. And we add the bone graft. And we replace the window back in. So now you can see that we've been able to exactly replace the window back in, and the results we will get with this kind of a situation will be pretty good. Another case here, we have about 3 millimeters of bone here, so we're going to do a simultaneous. And I'm going to show you about 3 or 4 videos, so it will give you a perspective as to what is the entire procedure all about. For those who are doing it, maybe there are some pointers that you may pick up. And if you have any questions, keep them coming so that Dr. Siddhant will be able to send me those questions and we can address them now. So this patient has 5, 6, 7 missing. We're going to place 2 implants and do a bridge, 3-unit bridge on those 2 implants. The first step we do is to open the flap and then take some blood to make the Ringer's lactate so that we can mix our, so we've already taken some bone out of there, and we can also sometimes use the window to use that as a graft bone. So now we are making the inferior, then go on the sides, and we'll make the And there you can see that we can see the purple. Then we are going in medially first and then inferiorly. So we release it from there. And now we are going posterior. We are measuring to see how much of the window and bone graft do we need to place a 10 millimeter implant, because that's what I normally would like to place in these situations. If you have, I would not want to place an 8 millimeter implant, and you don't need 13 millimeter implants in there. A 10 millimeter implant is good enough for most of our requirements. Now we are doing the osteotomy site. Once you've lifted the membrane, and I do make a mistake in this case, and you'll see it. We are placing so normally we like to place, and then once we've done the osteotomy site preparation, then we will place the bone first, because once you place an implant in, it will be very difficult to access bone in the palatal area. So we compress the bone in the palatal area first. So on the lateral wall of the palate. And then I will place an implant through here. Oh, there is no mistake in this case. I thought that there was one case which I don't know whether it's there in this presentation, wherein I placed the bone in first, and then I suddenly realized that I had to use one more drill, and so of course the bone was wasted. But not a mistake, but a thing that cost me some money. That was all. But this is not the case, and now we are placing both the implants together. And once you've placed the implants, then you will again go and laterally condense some more bone in there. This is a mix of bios and autogenous bone. Do you need to use a membrane in all the cases? Not really. We normally use the membrane in our practice when there is no attached mucosa there, because then the chances are that the soft tissue may sort of invade into the area. But if there is good amount of attached mucosa, we don't actually use a membrane unless there is a perforation of the Schneiderian. So, and you can see here we've placed 11.5 millimeter implants, and you can see a very nice lift of the sinus. Another case, in this case, we had about less than 4 millimeters of bone, as you can see, and we are doing again. I'm going to show you the video. Actually, sometimes if the interdental space is not enough, then if it's a premolar, for example, and you have to do a sinus lift, that can sometimes be a little bit more difficult because the interdental space is so little that your window really will not cover the instrumentation that you will have to insert to lift up the Schneiderian membrane. And that can be a cause of concern sometimes. So that is, again, your pressure point. Again, the Ringer's lactate is the first step. We're also opening the palatal flap. If I was not going to do a immediate simultaneous placement, and here again I'm measuring to see where I will mark two things I'm marking here. One is where my window should start, the inferior part, and which should be the superior most aspect of my window. Both are really important because that will give us, and remember, this is a single tooth. It's a 1/6. So we have to open a smaller window because we don't want to go too close to the roots of either the anterior or the posterior tooth. But at the same time, we must have adequate window creation to have proper instrumentation in the Schneiderian. So this is what we are checking to see if I have proper instrumentation access. Yes, I do. So I'm just releasing it. And I'm here, as you can see, I used a very small curette, not my large sinus instruments that I normally use. Then I will do my drilling protocol. Make sure that you don't drill too much beyond that, because even your implant drills can cause a tear in the Schneiderian. So again, that's your pressure point. And here we're making sure that we lift it up adequately. Then we will place the bone. In this case, we use pure bios because the patient was not very happy getting bone. As you can see, this patient is a foreigner, and she wasn't very happy getting bone from any other part of the oral cavity. So we decided to do it with only autogenous, with only allograft DFDB, demineralized freeze-dried bone. And here we are placing, I think, 10 millimeter a regular platform, so 4.3 millimeter diameter implant. And once you've placed the implant again, you will place the graft material from the lateral side. Once you've compressed it completely, make sure that you have adequate coverage of your flap. You do not want to expose anything. Then we suture up. And so you will first suture the crestal incision, and then you will suture the releasing. That is the post-operative CBCT. Again, it's an 11.5 millimeter implant. Then this is the second stage of the same patient, implant opening, followed by open tray impressions. We are making a CAD-CAM crown, which is cemented onto a universal abutment in the patient's mouth. Then we will access the screw access hole. We'll take it out, take off the crown. We will polish all the excess cement. And that is your final, before you cement the crown in the patient's mouth. This is your final X-ray, and that is the final result in the patient's mouth. Another case, these are multiple implants, and I think we're running short of time because we still have another presentation to go. But I'll just finish off with this and with this third case. I'm not show you the videos of the other one because they're exactly similar videos. So because otherwise we won't have any time for the Q&A session, which is very interesting for everybody, and including me. I get to learn from my Q&As. So this implant at the back, we eventually removed. These were not done in our practice, the previous implants. These are all failed. This is a failed case. I'm measuring to see how much bone I have. So we eventually removed the implant, which was that angulated implant that you see over here, because the dentist did not want to do a sinus lift, or was not trained to do a sinus lift. I'm not completely sure. But here again, we are opening a flap, doing the osteotomy site with a diamond round burr. And now we are trying to see if we can actually out-fracture it. That's how easy it is to out-fracture it sometimes. Then we're doing the medial release first. and then we did the inferior release. Now we're going to do the posterior release, and then we're going to do the superior release. So that is the sequence of events which you must follow. You must go all the way to the palatal bone, and you must go all the. And you can see that there is no perforation there, as you saw the patient was breathing when the Schneiderian membrane was. There was no leak from the Schneiderian membrane. You must also make sure that you go all the way anterior to the medial wall as well, so that you can pack in the bone nicely. And this is a mistake I've made now. You can understand what is the mistake. I know that one of the cases I made this mistake. I had to redo the bone again. Obviously, I lost that much bone because you can't obviously use that bone. And then I pack in the bone again because we've lost that bone. Now we pack in the bone again before we place the implants in. And now we're placing a wide platform 5mm implant, which is 11.5 millimeters in length. That's what I normally like doing for the posterior maxilla. That's good enough if you're doing a 10 or 11.5 millimeter length of implant. As long as you have a wider implant, then you don't need a longer implant. Now we're torquing it. As you can see, we are getting very good insertion torque of 45 newtons. That's what you want. Once you've done that, you will place the cover screw, and that's how it looks. And now we have removed the back implant, as you just saw me do, and now we'll suture up. So the advantage of using ringers is that at the end of it, you can even spray some ringers lactate on top so that it condenses the bone, compresses it, and you have a really nice result in that. Here we've given a vertical releasing on the palatal there so that I could open a palatal shelf properly, and that's the post-operative result. And here you can see we have 13.5 millimeters of bone, and we've placed an 11.5 millimeter implant. This is a similar situation, but maybe if you maybe some other time we should show you this. Let's do it, because otherwise we won't have time for the next presentation. What are the complications with sinus lifts? The rupture of the Schneiderian membrane is the most common complication, and it is reported to occur in 10 to 34% of our patients. In my practice, I would say it's about 1 in 6 or 7. So we obviously fall within the average bracket. Perforation of the maxillary sinus membrane is smaller than 5 millimeters. Then the survival rate is about 97.14 in Kim and Zhang's article. Decreases to 91.89% in cases of perforations with a size of 5 to 10 millimeters, and only 75% in cases of perforations larger than 10 millimeters. So that story tells you that if a perforation is more than 10 millimeters, abort the procedure. Wait for it to heal again and redo it. And Kim is a very good friend of mine. So this is something that we've discussed before. Decreases to 92%, which is acceptable, but you have to then either suture up, if the membrane is thick enough, you can suture the membrane, the tear is, or you must use a collagen type 2 membrane to cover the defect. Okay, so perforation will occur, like I said, in our case, 1 in 6 or 7 cases, 6 or 7 cases, you will do that. Very small perforations can be left untreated. But if you have a perforation of this size, then you must use a membrane to cover the perforation and then pack bone around it, okay, so that you can patch the membrane up. Other complication can include general surgical complications like infections, and so therefore sinusitis, because that's an infection in the sinus area, and nasal ecchymosis. This is something that you must warn the patient, because patients panic when they see any kind of marks around or blood coming out of their nose. Okay, so Siddhant, can we come to the next poll?
Yes.
Yep.
We are coming to the next poll. So you'll have to stop. Yeah. Okay. Just give me 1 second. Next poll. And here we are. Okay, still some votes to come in, but they will slowly.
Okay, so why don't we do that? Okay, so why don't we wait for the participants to poll, because now the participants are polling. So it might take a little while before everybody polls in. Do you do immediate implants in your practice? 33.3% do it themselves. So about 55 to 60% don't do it in their clinics. So that's also something. Next time we will talk about immediate implants. So if somebody is interested, is most welcome to join in to the next webinar, which we will announce. Sid, can you get out of the poll and
Yes.
look at all the poll results right at the end then?
All right.
Okay.
Back to you.
Yeah, thank you. So let's look at implant treatment in the edentulous arch. We have exactly half an hour to do this presentation, because I want at least 10 to 15 minutes of Q&A at the end. So what are the biological and anatomical considerations in the edentulous arch? It's the amount of available bone. So in the upper and the lower is completely different. You have to consider the upper jaw completely separate from the lower jaw, because the lower jaw between the mental foramina will normally you'll always be able to do implants in the lower jaw in between the mental foramina. While because the resorption pattern in the upper jaw is so different, especially above the sinuses and in the anterior region, in type C, D, and E bone, you will not be able to do implants in. While in the lower jaw, if you have type C and D, you will be able to do an implant. In my entire professional career of 32 years of placing implants, I have rejected maybe 2 or 3 patients in the lower jaw between the mental foramina because of a lack of available bone. We rejected them, or we've done grafting procedures in them. So this is very important in the maxilla, because so it's imperative that in the maxilla you will do the implants as soon as possible post extraction. Or of course, if there has been periodontal bone loss, which has caused dramatic degradation of the bone, then of course you have to do grafting procedures before. But the longer you wait in the maxilla with a removable prosthesis, the more you're going to have bone loss and inability to place implants in that. It's different in the maxilla. As you can see, even in type D and E bone, you will be able to do implants in the between the mental foramina in the anterior region, at least, if not above the inferior alveolar canal. So advantages of implant restoration, we know what the advantages are: improved function, stability, and retention, improved aesthetics, it maintains your hard and soft tissues, and of course, you will prevent bone loss. So what are the diagnosis that we need to make? What are the treatment planning? And what are the aesthetic evaluations that we will have to consider? So the contraindications are, of course, general medical conditions and contraindications. Any patient that you can't do a surgery on, you cannot place an implant in. So conditions and systemic disorders that could affect wound healing and the osteogenerative process, uncontrolled diabetes, clotting disorders, steroid therapy long-term, radiation therapy to the area, smoking is a contraindication. So at least we request our patients to stop smoking for 24 to 48 hours. The pacemakers, pregnancy, you don't want to do implants during pregnancy as far as possible. We have done it in case you need to. Osteoporosis, especially, those patients who are taking bisphosphonate therapy, drug abuse, a psychological profile, that's very important, etc. So these are the state of the patient's medical health that will not permit you. Of course, controlled diabetes is not a problem. Controlled disorders are not a problem. If you have a clotting disorders, you can always replace that factor that is causing the clotting disorders, and so on and so forth. Radiographs, very important. We now will recommend a CBCT for all our patients, because here you can measure the exact amount of available bone. And this is very important. All our lives before the CBCTs, we've had a CBCT in our practice for 10 years plus. Before that, we were using our clinical skills and OPGs at the maximum. Even before the OPGs came into existence 25 years ago, there were hardly any OPGs in the city. Those days, we were doing only IOPAs with a millimeter grids. So we have come a long way from where we started off. This is very important to understand. You have to evaluate the smile line for any edentulous rehabilitation in the maxilla. The mandible is not so critical, because the mandible, you cannot really see the confluence between the pinks and the whites in the mandible. But in the maxilla, it's very visible. So you must evaluate the smile line, you must evaluate the lip support, you will evaluate the phonetics, and if possible, you will evaluate the aesthetic trine without your buccal flange on your trine denture. So that way, it will give you a good idea and a good indication as to what you've achieved so far. So when you have your smile line, which is above the peri-implant mucosal margin, the aesthetic outcome is compromised. While, so that's the green. While if you have it below the teeth, the level is cranial to the smile line, then you have a better aesthetic outcome. Okay, so that's again very important to understand. So when it is caudal, then and you have to compare whether it is caudal or it is cranial. So higher or lower. If your gingiva is visible, you're in trouble, because your implant placement has to be very accurate. That is really your pressure point. If your gingiva is not visible when you smile, then your aesthetic outcome is going to be better. So also, you must consider what are the amounts of bone available in 3 zones. We divide the 3 zones into the anterior, the premolars, so the anterior is canine to canine. The second zone, the zone number 1 is canine to canine, zone number 2 is premolars, and zone number 3 is the molars. If you have zone 1, 2, and 3 available, then the whole world is open to you. You can do 6, 8 implants, whatever you want, not a problem. You can do all on 6 and even more. If you have only zone 1 and 2 available, again, you have 2 options. You can do all on 4s, or you can do a sinus lift in the zone 2. You can do all on 4, or you can generate bone in the third quadrant, in the third zone with a sinus lift, and then do an all on 6. If you have only bone in zone 1, then you have 2 options. Either do a sinus lift and generate bone in zone 2 and 3 bilaterally, or you can do a zygoma. You can do zygomatic implants and do an all-on-4 on the zygomatic implants. So this is your evaluation. This is your criteria for selection of how many implants you're going to place. So we do anywhere between 4 and 8 implants for each for the maxilla, and 6 implants, 4 to 6 implants in the mandible, and that is more than adequate to restore your entire occlusal schemes. So what are the options you have in generating the prosthetics? You can either do sectional bridges, like the case on the left-hand side. You can do the middle case, which is a implant bridge, which is implant-supported, screw-retained implant bridge, and which is purely implant-supported. And you can do an overdenture, which can be purely implant supported, or it could be an implant and tissue supported overdentures. We now very rarely do a lot of overdentures. We used to do them a lot in the earlier days, but now we're only doing it in medically compromised situations, wherein doing sinus grafts or doing grafting procedures is not so indicated in these patients. They don't want to undergo multiple surgical procedures. They don't want, where we can't do multiple, we create multiple morbid sites. You want to restrict the number of surgical procedures. Those patients, we will do an overdenture. So the most important part of the diagnostics and treatment planning is to have a software that will let you plan your implant placements. So there are multiple number of softwares available that will let you plan. And today, like I said in my previous lecture, we can even fabricate our own guides. This is what we are doing. Sometimes you can make your own guided procedures. And like I showed you last time, I showed you a case with a guided surgery. I don't want to talk about that today because we've already covered that. People who haven't heard it can go back to my previous lecture and they can access that and they can see that guided procedure. So this is an overdenture case for a Paris bar. The patient is an older patient. She is 80 plus. She did not want to get any sinus lifts because there's only zone 1 and maybe a little bit of the 2 is available. So we could only place implants anterior. You don't want to cantilever your prosthesis back so much. And so therefore, this is what we did for her. We extracted her teeth. This is preoperative. OPG after the implants. She did not want to undergo any kind of grafting procedures. Implant opening after 3 months. Not the ideal location, but for what we're going to do now, it was a very good solution. This is a non-surgical procedure, but even though we are doing a surgery, as you will see now, there's a lack of attached gingiva there. And when the prosthesis comes on top, it's going to be a food trap. So you need to create a nice, viable band of attached gingiva. We're doing a laser vestibuloplasty. As you can see, there is very minimal and no bleeding. So the healing potential is very good. This is after 10 days, and we've got now a beautiful band of attached gingiva. We'll take an open tray impression. These are the implants after we've opened it. This is the Paris bar. And this bar is cantilevered back, but it's supported on the implants. It also has the overdenture abutments incorporated into the bar, and on which we will fabricate a removable denture which clips into your overdenture attachments. This is your final, and you can see the cantilever, but that is a tissue and implant supported bar. And so therefore, we are not cantilevering it in the true sense of the word. This is your Paris bar, and you can see there's a tissue contact posterior to the last implant. And this is the final prosthesis. It's a clip-on denture which goes into those attachments on the Paris bar. That was what we do now in our practices if we have to do overdentures. This is a case, 76-year-old male, history of diabetes mellitus and hypertension. I'm quickly going to go through this. I just wanted to show you a case wherein, and this is a very old case, I'm going to show you follow-up of that. Again, we have only zone 1 in this patient. So we did a sinus lift bilaterally in the maxilla. And the lower, there's adequate bone. We placed 5 implants with a guide. This is the planning on the software. We placed the implants on the same day. We loaded it with the temporary prosthesis. And as you can see, this is what we've done. And on the upper, we did a direct sinus lift. And after the sinus lift was, and here you can see the sinus lift done with the implants placed. We placed the implants. This is an X-ray we took to have a look at the parallelism of the implants, of course, and our impression copings. And you can see that the upper implants are not done with a guide. They're done with my hands. And we made a Procera implant bridge for the patient on the upper, lower prosthesis. You saw this is in protrusive. I wanted to show you a picture where there is proper balanced occlusion here. And this is very important for the long-term stability of your implant cases. I am rushing through these cases. simply because in your leisure time, you can go back and have a look at this. This is a case with a 67-year-old male. This was a difficult case because he had a coronary bypass surgery. He was on oral anticoagulants. And these are the kind of patients that you get because this is geriatric dentistry in the true sense of the word. This is maxillary preoperative. We placed the implants in. On the same day, we took the impressions for temporization. We gave him a fixed temporization. He was wearing a denture already. This is immediately post-operative 1 week. This is not important. We'll talk about this next week. We gave him the upper temporary prosthesis. This is 3 months post-operative. We placed immediate implants on the lower. And you can see the soft tissue profile. We take the final impressions for both the upper and the lower. In this case, we are going to do a sectional bridges on the upper. We've placed 8 implants in the upper, and we've placed 6 implants, and we always use a semi-adjustable articulator to get us the movements of the mandible against, because in implant prosthodontics, it's very important that you balance the occlusion perfectly, and that you do not stress the implants too much, especially since you're using a ceramic as a coverage material. Maxillary sectional prosthesis in 3 parts: canine to first molar, lateral to lateral, and canine to first molar on the other side. The mandibular hybrid prosthesis, as you can see, the screw access holes. This is a what we call a Procera prosthesis with a titanium inner and a ceramic layered surface on top. The final prosthesis cemented and screw retained on the bottom and cemented on the top. And this was the preoperative and the post-operative OPG. As you can see, this was taken immediately after the lower extractions before we placed the lower implants on the same day. And this is a 3-year recall period. And we removed the lower prosthesis, and you can see that the patient has been able to maintain his oral hygiene very well. This is very important to understand. If there is food impaction, if there is no attached gingiva, there is going to be food lodgement there, and you will have plaque accumulation, and you will have to service this prosthesis regularly. We do this for this patient once in 3 years now. And we found that he's been able to maintain his oral hygiene very well. So it's quite good. And this is a CBCT we took in the upper arch after those, I think this is after 4 or 5 years, post the implant placements, just to check that the health of the implants was good. You can see the mandible and the maxilla. And you can see that there is no, I'm showing you some older cases, so I can show you a follow-up of that. 62-year-old female with no relevant medical history, but this is a very interesting case. This is implants done in some other practice, and you can see that all the implants have failed. And this is a CBCT. I think this case was done about 3 or 4 years back. Again, I have 3-year follow-up of this patient. I don't want to show you any cases without follow-ups. This is what it looked like preoperatively. So when we opened up, this is before we took out the implants. When we opened up, you'll see the amount of damage done. We removed the implants. After the implant removal and the bone grafting, this is 6 months down the line. This patient took us about a year, I think 9 months for us to finish the entire case because the damage was so severe. Obviously, you couldn't do the bone graft at the same time as the old implant removals because of the amount of infection. Even if we have laser, that's a chance you don't want to take. So as you can see now, we have nice bone formation there. We have nice cortical bone, and we got type 2 bone in this case. Then we did immediate implant placement in 2 areas. We placed 6 implants. We kept the 7. The patient wanted to have at least 1 tooth of her own. So we said, okay, that's not infected, and we don't want to give her a 7 in the future, even if we have to extract that tooth. So it doesn't matter. And this is how the implants look on a CBCT. Now, when we had extracted everything and done the implant placement, this was preoperatively, we discovered that there was no attached gingiva. So what do you have to do? You have to do a vestibuloplasty. And I'm going to show you an amazing technique to do vestibuloplasty with. It's with a laser. You can use any erbium laser that you have. This is a long video of about 5 minutes, but it will tell you. And so we are going layer by layer, as you can see. And what you can appreciate is that there is hardly any, there's virtually no bleeding, or there is no bleeding. As we go layer by layer, reaching up to the periosteum, and then we will score the periosteum so that we get the attached gingiva, the gingiva above the scored periosteum to attach to the periosteum, because otherwise the soft tissue will grow over there and there will be a recurrence of the same an earlier lack of attached gingiva as we had before. I can't go beyond that point, and now, as you can see, we are going, you can see the periosteum. Of course, when you will score the periosteum, you will have some bleeding. The periosteum is highly vascular. I can't go beyond this behind this point simply because of the mental foramen. And now I'm going on the other side. Let me go forwards on this. And then we are now scoring the periosteum. You can see this is still not the periosteum, but when you go deeper down, then you will find that we are scoring the periosteum. There you have it. Can you see that we've scored the periosteum there? And it's still not bleeding very much. So this is an amazing technique, but you need an erbium laser for this. And you will find that this is where the soft tissues will attach post the healing. You can see the scar tissue there, and we've created a nice band of attached gingiva. This is 3 months post-operative from that point. And now we are opening the implants, and here you can open the implants with whatever you want. We're using lasers, 2 different lasers. One is an erbium laser. Again, no bleeding. And this is a diode laser. So all those people who have diode lasers in their practices, I know that there are a lot more people with diode lasers in their practices today than there were in the earlier days, and a lot more diode laser users than erbium laser users. This is something that is so easy to do, even with a diode laser. And the healing, even though this looks more angry, the healing is exactly the same, as I will show you. So on one side, we've done 3 implant opening with an erbium laser. On the other side, we've done it with a diode. And you can see that there is instant hemostasis. You can do hemostasis as long as you know what you're doing. So there is not much of bleeding around that area. On both sides, you will see that there is total hemostasis. And now we're opening. The pressure point in this procedure is identifying where the implant is. So what you do is you take your probe and you probe into the screw access on the cover screw, where the screw access hole is on the cover screw. You place your probe around it, and then you start going around that area. And now we take it, and that's how it looks. On the left side, done with an erbium, remember. On the right side, done with a diode laser. That looks a little bit more angry. Immediately after implant opening, this is exactly on the same day. This is 1 week post-operative, and you can see that both the results look exactly identical. So there is no long-term difference with the diode laser as compared to an erbium. This is how it looks 1 week operatively. This is final prosthesis. This is just to take the trial of the prosthesis to check that the fit is good. As you can see, there are 2 implants which have not been fitted in well. So we went in and we did the required thing for the great passive fit of the prosthesis, final screw-in hybrid, and this is the final prosthesis in the patient's mouth. Now you have an attached gingiva, and there will be no food impaction there. Unfortunately, the patient didn't want me to change the bridge and the upper. She was not so concerned about the aesthetics, though I was wanting to do veneers on the canines and change the aesthetics, and I would be able to give her a much better smile. But she is happy with this. And that's how she looks now. 3 years post-operatively, we took off the prosthesis. That's how it looked. We just polished it, cleaned it up. Now you can see that's 3 years down the line. And of course, the patient has to use brushes, which are now electronic brushes are available. A lot of companies are making it. So I will advocate that we give the patient an option that we can use an electronic brush that goes underneath the implant so that they will be able to maintain the oral hygiene well. This is a case I was talking about, 60-year-old male, squamous cell carcinoma of the buccal mucosa, history of submucous fibrosis, so reduced mouth opening, history of palm chewing, and bruxism. And that's the reason for the submucous fibrosis and the squamous cell carcinoma. Operated on, this is what the patient, the OPG looked like before we started the case. This is what he looked like in the mouth, a completely collapsed dentition. Preoperatively, immediate implants placed. Remember, the gingival health of the patient, we improved it before we did the implants. So we placed the implants, maxillary distal angulated implants, lower implant placement with a bone grafting, immediate implant placement, mandibular and maxillary, and this is the final prosthesis in the patient's mouth. This was one of the most difficult cases that I've ever done, simply because of the lack of mouth opening. He had a 2-finger opening, and we had to do his prosthetics simultaneously, because otherwise to take an impression of the opposing arch would have been extremely difficult. And this is the buccal view, and this is the lateral view. This is in the patient's mouth, the final fit of the prosthesis before and after. And this is an acrylic. You can understand why we did not want to use ceramic as a layering material. So we used acrylic and acrylic teeth as a layering material. So acrylic was used as a layering material. This is the final case I'm going to show you, because we are already running out of time. This is one of the cases that I'm really proud of. Ectodermal. I did show you a glimpse of it last time. Ectodermal dysplasia with total anodontia, one of the rare cases that you will find. Now, this case we saw in 2007, and we finished this case in 2012 or 13 or 14, because the patient, the first thing we actually did was to do a graft on the maxilla. As you can see, there is absolutely no bone in the maxilla. When there are no teeth, deciduous or permanent, there will be no bone. So we did a graft. We took an iliac graft, and we did a graft. But then, unfortunately, the patient had tuberculosis. And because of tuberculosis, the graft just did not work very well. So then we decided to do zygomatic implants for him. These are and all-on-4 on the lower. So we post-implant placement, the upper and the lower. This is the final prosthesis. We did 2 zygoma implants, 3 implants in the anterior region, even though, so that was a compromise situation, because we lost one of these implants, the middle one, in the future. And you'll see that in the next slides, you'll see. And the lower, of course, was, so this is the occlusal view of the upper again. It was a PIB, acrylic layering. You'll see the height of the prosthesis. It's really, really long. And so I didn't want to use ceramic because I would stress the implants too much. In the final prosthesis in the patient's mouth, this is 1 year post-operative. This is pre and this is post. This patient, it's a very rare case, complete, total, deciduous and permanent anodontia, ectodermal dysplasia. By the way, I must tell you a story. When we delivered, remember, this was a young child. When we saw him first, not young, but he was about 18. When we finished the whole treatment, because we couldn't do anything for 3 years in the middle, it was approximately, he was in his early 20s. When he's, for the first time in his life, when he saw his fixed teeth, he wept for half an hour. And that was the ultimate compliment, wept out of tears of joy that he finally had teeth in his mouth. That was the ultimate compliment for me. No amount of money or other adulation can ever replace that experience that I had. So I always show this as my case whenever I lecture on implants. Our next webinar, of course, is on Sunday, the 18th of October, between 7 to 8:30 p.m. We're going to talk about laser dentistry, which will also include immediate implants, soft tissue surgeries with lasers, aesthetic crown lengthening and aesthetic procedures with lasers, including depigmentations and other interesting procedures that can be done with lasers. If you have any suggestions, you can send them to me right now. We can include that in our presentation for next time or the times following that. We're also thinking of doing this as a continuing process. Every month, we could do one webinar on different tracks of dentistry. And there will be other speakers apart from me who will come in and give their expert knowledge in their other fields. So thank you very much. And thank you for listening to this presentation as well. So Siddhant.
Okay, so the first thing I'll do is I'll go into the polls.
Correct.
And then after that, we'll come back to the questions.
Absolutely.
Okay, so. All right. So firstly, do you do immediate implants in your practice? About 48% do it. They do it themselves.
And 23% get somebody else to do it in their own practices.
Yes.
And about 30% refer it, either refer it or don't do it. About 20% don't do immediate implants. Okay. So that is also a telling comment on what we should do next time. We should put in immediate implants as a part of the presentation in our practice. Okay. In our next lecture. Okay.
Full arch rehabilitation, about 50% do it.
Okay, so that's very
if they do it, yes.
That's very interesting because about 21.1% do all on 4, 20% do, there are more votes coming through. All on 6 do, about 8.7% do all on 6. Sectional bridges 16% do, and 60% do all of the above.
Yeah,
that's interesting. That's interesting because that means that they're like us, that we offer everything in our practice. That's great.
Okay, so again, we'll just come back to the first 2 or 3 questions. How many are doing implants in the practice? About 45%.
My interest here is the 30%, or the 20% who don't do it.
Yeah.
That is, again, a telling commentary on some of the practices that there are still out there who may want to upgrade their skills. And of course, there are lots of courses available. I run a fellowship in implant dentistry at DY Patil. I'm using this opportunity to plug that course as well because I think it's one of the better courses that are available in this country. Because we're taking you from scratch all the way up to at least getting some experience with sinus lifts and stuff like that. Okay, the next one, Siddhant.
How many people restore implants? About 70% roughly will restore implants in their practices. If not themselves, then they get someone else to do it.
Again, interesting because about 40% of the people are doing it themselves. I would have expected that figure to be a little bit higher. And about 65% do it in their practices. Either they do it or they get somebody else to do it. And about 19% refer them out. And 12% don't do. So these may be the same people who don't do implants in their practices. Correct. So maybe that's something that again, that's an area of opportunity for all of them to get some education and start incorporating that in their practices. Okay, the next one, Siddhant.
And this is the last one. How many do you do a sinus lift in your practice?
Again, I find this interesting because about 50% will refer it or don't do it. And about 50% do it in their practices. Either they do it with somebody else, like a specialist coming in, or they do it myself. I think 35% of people who are attending our programs and doing sinus lifts is a large number. So I'm surprised that 35% are doing sinus lifts. So, but of course, I'm happy that 65% are not doing it or getting somebody else to do it. So again, there is an opportunity here for educational courses that they should do, educate themselves and incorporate that into their practices. Okay.
Okay, I'll move on to the questions now. I'm just going to stop sharing my screen.
Sure.
And I will move on to the questions. So there were quite a few interesting ones. I'll start with the ones on the sinus lift. First thing, someone wants to know, how will you know if the drainage from the middle meatus has been maintained?
Yeah, the only way you can do it is take a CT scan. And of course, if there's a blockage, there is the patient complains of stuffiness in the nose, so you will have to go with symptoms or get a CT scan done. That's the only way out of that.
Okay, second question on that. Someone asked, during a premolar or a molar extraction, there's a perforation into the sinus. Now,
Right.
In that case, can you do a sinus lift?
Can you do a sinus lift immediately? Is that what he's asking?
No, they've just asked that. They haven't asked immediately or delayed.
Yeah, you'll have to allow it to heal.
Yeah.
If there's a perforation of the membrane, what he's asking is if there is an OAF. Is that
basically if there's an OAF, can you do the sinus lift in that case?
I mean, you'll have to then judge it once you've closed up the OAF. Then the Schneiderian membrane should heal. The healing potential of the membrane is very good. Take a CBCT, check it, and if it's there. By the way, I must tell you that there has been one patient that I have treated, and that was the only one I've actually treated, when I opened up, there was no membrane. There was no membrane there. So obviously we had to abort the procedure and close up, but that's the only time I found that happening. Now, I don't know why. Maybe there was a pathology there which was not detected earlier, or I don't know why there was no membrane, but there was no membrane. So anyway, so the question here was, once you close up the OAF, allow it to heal, and then if you get the Schneiderian membrane formed and bone above it, yes, you can do a sinus lift at a later stage.
Okay, another question on that sort of, in that sort of note, how do you manage a very thin Schneiderian membrane?
Right, so that's a difficult thing. So there are two problems with a very thin Schneiderian membrane. The Schneiderian membrane, if it's very thin, but is not adherent, is very easy to separate. If it is adherent, and particularly if it has a raphe, which is a very sharp, thick, which is a thin but adherent raphe, then the tear is very common, and these are the areas where you will have a tear. So even if you do tear, make sure that you will use a membrane over it. If the membrane, Schneiderian membrane, is very thin, is not adherent to the underlying bone, then there is never that much of an issue. You can separate it very easily.
Okay.
Just one more thing. Also, when you're doing the packing in of the graft bone, make sure that if the membrane is very thin, you don't overpack it with a lot of pressure, because then you're again likely to tear it. So keep it tight, but not overly tight packed. Not loosely packed, not overly tightly packed, just adequately packed. Yeah, sorry, go ahead. Next question.
Okay, next question. What is the role of PRF in grafting procedures?
So, very interesting question. But if you had looked at the review in that study that I had shown earlier, they did not find any difference whatsoever. They used PRF plus allografts, I think, or autogenous bone. I think they used PRF plus allografts, and they found no difference in fact, the rate of success was slightly lower, because PRF, remember, is a soft tissue material. So unless they're using the PRF as a membrane to cover the defect, and I haven't found any studies. If you have found any studies, please send them to me. But I haven't found any studies which are talking about the PRF used as a membrane to cover the lateral defect. I was talking about using PRF as a graft material and mixing it with either autogenous or allograftic bone. And then the results showed that there was a decline in the bone formation.
Yeah, I just wanted to add that most of the studies with PRF don't actually they're inconclusive. There's no evidence to support that PRF in a sinus lift will actually help the bone formation there.
Exactly. I would not want anything soft in my bone there. I'd rather have densely packed, bone. I don't want anything which is soft tissue in there.
Okay. The last question that I thought was quite interesting was people were asking whether in sort of the event, instead of doing a silence lift, would you do basal implants? Is that which way do you go on that?
I would not want to comment on basal implants because I do not believe in that. Because I haven't done. Let me say this much, that I think it is a very aggressive way of placing implants in, and the problem is not if they integrate. The problem is when they fail. We have had to treat several patients where the failures of basal implants have been so detrimental that the patients are in real psychological stress. When you do implants that we place in our practices, which are basically screws or cylinders, it is very easy to replace those implants. When a basal implant fails, there is a complete destruction of bone. I have not done basal implants, and I therefore would not want to comment on the efficacy or success of the basal implants. Suffices to say is that it is very, very difficult once the implants fail to restore them back to their health.
Yeah, that's it.
Okay, so thank you very much for everybody. And I know that there were, yes, thank you very much. And Anthony, can you give a vote of thanks? And I would like to thank all of the participants in this program. If you have any questions, you can email me. Even my email address is very simple. My whole name, Suchetan Pradhan, no doctor please, @gmail.com. Or Dr. Suchetan @pradhandentalcenter. Anthony, please take over.
Thank you, Dr. Pradhan, and good evening, everyone. We sincerely thank Dr. Pradhan for such a extremely insightful session on advanced implantology. I'm sure all the audience would have huge learnings today to take home. We also sincerely thank Dr. Siddhant Pradhan for moderating this show. He picked up all the important and the most interesting questions as well. Alkem is the 5th largest pharma company here in India, and we are in the service of the medical fraternity for the past 40 years. And our endeavor is to become the most trusted partner for the dental fraternity, leading brands like Clavam, Enzoflam, Pan40, and Pandy. And like we have said earlier, the 3rd webinar of this series is scheduled on the 18th of October, and the topic is going to be laser dentistry. And in case if you want to listen to more such topics, you can either write to Dr. Pradhan directly, or you can communicate to us as well. And to encourage us to do more such programs, we request you to give exclusive prescription support for our brands like our Clavam, Pan40, Pandy, and Enzoflam. So till the time we meet next time on the 18th of October, we wish that everybody is safe, stay healthy. So good night, take care, and Jai Hind.
Thank you very much.
Thank you.
Thank you.
Thank you.